All right, folks. Just to remind you all that we were talking about this lovely condition here. Well, not lovely, but this condition here, erythroblastosis fetalis, also known as the hemolytic disease of newborns, right? And how this is caused when you have a mother who is rhesus negative. Remember, rhesus is an antigen found on the red blood cells, right? You either have it or you don't. If you have it, you're considered to be positive. So that makes your blood positive. If you don't have the antigen, then we consider your blood to be negative, right? Now, I think I also mentioned the majority of people are going to have negative blood, okay? Sorry, positive blood. My apologies. This lovely chart here is just showing you the breakdown of blood types in Jamaica, right? So the blood bank provided this. So as you can see here, the bulk of people are going to be O positive, okay? So the person you meet on your daily basis, chances are it's almost a 50% chance that they're going to be positive. Yeah, I'm getting noise in the background again. Right? So when we do the blood test next week, I'm expecting at least a third of the class. Somewhere between a third and a half of the class should be O positive, right? And you'll notice that the next two are going to be A positive and B positive, right? Now, here's the thing about A positive and B positive. The A blood type is more common in Europeans, right? Talking about pretty much white people. And the B blood type is more common in Asians. Now, please keep in mind when I say Asians, oh, my camera went out for some reason. Anyway, when I say Asians, I also mean Indians, okay? So Indians are also considered to be Asians. So your Chinese and your Indians are all going to be more common, right? Now, generally speaking, Africans or people tend to be O positive, right? That's by far the most common blood type in Africa. So the reason why the distribution of blood type in Jamaica is like this, of course, is because most of us have African ancestry, right? But quite a few of us also have mixed ancestry, which of course means either Europeans or Asians, which is why don't expect that you're necessarily going to have O positive only in the class, right? All right. Now, AB positive, of course, you notice here that's only 3% of the population. So I'm AB positive. Right? I think somebody else in the class indicated they were AB positive, right? So we are a fairly uncommon blood type. And remember, we are the universal recipient. We can get blood from absolutely anybody. O negative here is, of course, the first of the negative blood types I'm going to talk about. If you notice here, if you add up all the negative ones, that's 3.5 and 2, that's 5.5, 6.5. So everybody is up. What is this? What is going on here? So everybody adds up to 7%, right? So 7% of the population is negative. Let's assume half are female. So 3.5%. I don't know why it keeps doing that. So 3.5% are going to be female. If you happen to be one of the 3.5% who have negative blood, which means no rhesus factor, right? It means chances are, remember what we said, chances are the father of your child is going to be positive, strictly based on statistics. Right? If damn near 96 to 97% of the population is positive and you are negative, it's gonna happen, almost certainly gonna happen, right? And that, of course, is what brings us back to this erythroblastosis fetalis. And I remember what you were saying when I spoke to you last week. If the once the baby is conceived, because the father is probably going to be positive, the baby will also probably be positive. If the mother gets exposed to the baby's blood, she becomes sensitized. She starts to produce antibodies, which are the Ys here, against the rhesus factor in the baby's blood. So when she gets pregnant again, the baby, fetus in this case here, the antibody will cross the mother's blood by the placenta into the baby's bloodstream, agglutinate the baby's blood, and kill the baby, right? Hence, she has a miscarriage. And of course, every time she has a positive baby, she will end up with another miscarriage, right? Just to remind you about agglutination as well, right? Remember, agglutination is clumping up of the blood caused by antibodies. So next week, we're going to be doing agglutination tests. So this here shows blood agglutinating. Shows this forming little clumps in it, right? And this will be a positive test. This here will show a negative test. So here, nothing is happening. So next week, this is what we'll be looking for when we're determining your blood type. Testing, you have a question?
Yes, sir. You said that every time the mother has a baby and the baby's blood is positive, that means that the baby blood needs to be negative for the mother in that photo, right?
If the baby's blood is negative, then she'll have a problem. But chances of the baby's blood being negative are pretty low, right? Considering who the fathers, right? Statistically, the baby is probably going to be positive, right? All right. Anyway, let's continue. So that was just just to remind everybody about it from last week. Now, also, I mentioned the stuff here, ROGAM. Now, ROGAM is what a negative mother will have to take in order to try and increase the chances of her having a baby without severe complications, right? Now, generally speaking, I think it's 2 doses you get via injection. Let me see. I think it's 1 during and 1 immediately after. Right. So you're given ROGAM at 28 weeks and within 72 hours of the baby's birth to reduce the chances of the mother becoming sensitized. So if the woman is pregnant and she knows already that she's negative, the ROGAM is supposed to stop her from becoming sensitized. All right. Now, as I said to you, I'm trying to. I think the stuff is relatively expensive, so I think it's somewhere between 50 and $100,000 per dose. Don't quote me, but I think it's something like that. And you need 2 doses, right? Go ahead, Jesset.
Yes, afternoon, sir. I don't remember the name of the test that they do during pregnancy, but only if they see where signs of the mother being sensitized, they routinely get the ROGAM, and they get the ROGAM postnatal only if the baby is positive.
Well, keeping in mind that only if the baby is positive, there's a risk of a reaction,
Yeah.
right? So that makes sense. But if they know the mother is negative and the baby is positive, she really should get the ROGAM during the course of the pregnancy. This reduces the chance of her becoming sensitized because remember, there is a risk that the mother's blood and the baby's blood could still mix during the pregnancy itself, right? Not just during the process of childbirth. I am assuming they are limiting when they give the babies the ROGAM for a couple of reasons. One, if it's a public clinic and they're using public money to buy the stuff, they're very careful about how they distribute it. They're, I don't know if you ever heard the term niggardly, but the hospitals can be very niggardly when they're giving out the medication because of that. Because they just don't have a lot of it. Right? So, and two, as I said, they really should, if possible, get the second dose just in case. Right? So yeah, I agree with you. They probably do it that way, but realistically, they really shouldn't. Right? All right, let's continue. As I said earlier, the RhoGAM is going to prevent hemolytic disease of the newborn. That's erythroblastosis. It's an anti-RH antibody that will essentially bind to the rhesus antibodies in the mother's blood if she gets exposed and prevents the mother's immune system from reacting to it, right? Now, let's talk about blood transfusion real quick just to make sure that we're all on the same page. What you're seeing here is what you'll be doing next week, assuming I show up. Tim Mary, I have a question. Your mic is open.
Oh, my bad, sorry.
Okay. So what you'll be doing is that you'll be taking, well, in this one here, they have 4 drops, 4 drops of blood. We don't need 4. We're only doing 3 drops. These here are antibodies. Okay. So we're going to be using anti-A, anti-B, and anti-D. We don't normally use anti-AB, at least not for our purposes. All right, so we're using these 3. And what they're basically doing is this. You prick yourself with a little machine that'll just press the trigger and it'll pop in and you get some blood. And we have used slides instead of cards. If you go to the blood bank uses these cards, right? So what you do is you put a drop of blood on a card or a slide, then you put a drop of the antibody on the blood and you mix it together, right? The idea here is very simple. The anti-A antibody is only going to respond to the A antigen on somebody's blood, okay? So if your blood type is O positive, as an example, then obviously there's no A antigen on your blood. All you have is a rhesus antigen. So when you mix the anti-A and your blood, nothing will happen. There will be no agglutination, right? Which means your blood looks like this one, right? Remember, that's no agglutination. Now, if you are, so you mix the anti-A, nothing happens. You put another drop of blood down, you mix the anti-B, of course, nothing's gonna happen again. Because if you're O, it means you do not have antigens for either blood type A or blood type B. But when you mix now the D, the anti-D here is for the rhesus factor. And remember, the vast majority of people are positive. So chances are, when you mix anti-D, it is going to agglutinate. And if you look on the card carefully here, you can see the third one here, which is actually anti-D. I know it's a little hard to read at this distance, but this one is starting to clump up, right? This one is agglutinated. So this person here is O positive, right? As I said, I'm expecting this to be the most common blood type in the class next week, right? Now, we don't need to do anti-AB, of course, because once A and B are negative, or A and B are positive, you can determine somebody's AB, right? So this here just shows you what you're expecting your slide to look like next week, right? So if your blood type is O positive, you're expecting, remember, we're doing these 3. So A, B, D. So I think that's A, B, D, right? Then now, if you're A positive, of course, it's going to look like this. So you will have 2 sections that are clumping up, right? And B positive, you'll have 2 as well, right? So once you have 2 that clump up, chances are you're A or B positive. If you only have 1 that clumps up, chances are you're O positive, right? So it's a really, really simple experiment. It won't take you more than about 10 minutes, 5 minutes, right? And then we can move on to dissecting the heart and doing the other things. All right. There are charts and things like this in the lab manual that you'll be filling out. So we'll leave that for them. All right. This is just another blood typing chart from Jamaica, right? No, I think I also mentioned to you how, first of all, can I assume everybody knows that Jamaican people do not like to donate blood on average? Usually speaking, right? I can tell you, if you want, so it has been my experience, if you want somewhere quiet to sit down and undisturbed, just go to the blood bank, right? Go to where they have actually the blood donation centers. There's damn near almost never anybody in there, right? I've donated blood about what, 5 times now? Go ahead, Carola.
Sir, I think some of us want to, but our blood count is just too low.
Maybe. I'm going to go through some of the requirements for blood donation. For giving blood in Jamaica. I mean, I should think they're fairly easy. I should think for the average person to reach, I should think. Give me 1 second here. I'm not sure why the slide isn't on here. Let me add it. In the meantime, that said, the vast majority of people can very much donate blood, right? Yes, you'll have the occasional person who has a problem, don't get me wrong, but most people don't want to do it, right? I mean, like, what am I going to say to them? If they don't want it, they don't want it, right? All right, so here are the criteria for giving blood in Jamaica. 70 to 60 years old. I'm assuming everybody in here fits that. 110 pounds and over. I have not seen you all, so I don't know, right? Maybe 1 or 2 of you are a bit undersized. I assume based on the average age in the group, you're not suffering from a hypertension, right? And by the way, asthma is a clinical diagnosis. People always say, oh, I have asthma. Unless the doctor tells you you have asthma, you can't say you have asthma, right? So this one always comes up, oh, I think I have asthma. Only if you're clinically diagnosed with asthma, you have asthma. Sickle cell. You should be getting blood, you shouldn't be giving it, right? I'm assuming there are no diabetics in here as well, right? Now, this one here, in the past, people with tattoos or lots of piercings were not allowed to give blood. Does anybody know why?
Because of the needle.
What about the needle? What difference does that make?
So I think they said because with tattoos, like it must go drain out to the people in blood. So you
No.
know what? As over here.
Foolishness.
That they may not change the needle between the persons that they're tattooing. So like
That's a part of it. That is linked to the reason. What difference does that make?
Sir, STI and those stuff.
Uh-huh. There you go. Here's the thing. First of all, when they do the tattoo needles, the ink is being put in upper layers of the dermis of the skin. The ink is not going to move into the capillaries of the blood and get into your bloodstream. All right. So that's a foolishness. The real reason is that a combination of not, first of all, in the past, keep in mind, this is mostly for the past, they would use the same needles that tattoo over and over and over again. These days, I think most tattoo parlors, they use the needles and then dispose of them, right? But for people who used to reuse needles, it would be very easy to take HIV blood from somebody and then tattoo another person with it, and all of a sudden you have the HIV issue. But it wasn't even really the HIV as much as it was herpes. Right? Herpes is another one of these viral diseases that is more common than HIV and is very easily transmitted in this way. It doesn't take a lot of blood to pass on herpes. Generally speaking, HIV takes a little bit more, right? And the testing done in Jamaica, at least in the past, for herpes was not very good. So you didn't want to take the risk of it because if you give somebody herpes, then they're liable to have an issue with it, right? These days, of course, the testing for herpes is a little bit better, as is the testing for HIV. So if you've had your tattoo for more than a year, if you did have herpes, it would show up in the current test. Same thing with HIV. So even if you have tattoos these days, as long as they're at least a year old, you can still give blood, right? So now, of all the factors, how many people in here have any of them? Right? And remember, to say you're anemic or asthmatic is a medical diagnosis. You have to be done by the doctor. You can't wake up one morning and think you have it, or your mother can't tell us you have it. What's
Sir,
yes, go ahead. There was a question. I saw a hand go up. Okay, I guess I'm wrong. I thought I saw a hand. Okay. Now, generally speaking, it's the last thing I'm going to say about the blood bank is that your hospital is running with about 60% of its requirements, between 50 and 60% of its requirements for blood, right? So they're always chronically short, right? So if you do feel the desire to do something good for society, and it is society we're talking, donating blood is a good place to start, right? Just think about it, you know? As a matter of fact, I think as nurses, you're supposed to give blood in either second or third year. I don't remember exactly which one it is, but we'll see what happens. And of course, you get a free STD test part with the blood, which is always nice, you know. And you break it up, Nadia. Right, I didn't hear a word of it. I don't know if you want to type something in the chat or what, but I didn't hear a word of it. All right. So let's now talk about the types of red blood cells. White blood cells, sorry. Now, leukocytes. Remember that your red blood cells are by far the most common blood cell, right? But your white blood cells or your leukocytes are a major, major component of your immune system in general. Some of the things that they're responsible for. They help to remove toxins from the blood. Toxins, of course, can come from several sources. For example, eating food that is spoiled, right? Sometimes when you eat the spoiled, you eat the spoiled food, even if the bacteria is destroyed by the acid in your stomach, as the bacteria is consuming the food and replicating, the bacteria, of course, is releasing toxic chemicals into the food. So that means that even if the bacteria itself is killed off when you eat the food by your gut, you can still absorb toxins into your body, right? And then your leukocytes have to clear these with the help of your liver. So keep that in mind. Also, if you get bacteria within your body from a cut or a bruise or something, they also produce toxic chemicals that have to be removed as well, okay? And of course, your immune system cells are also there to remove pathogens from your body, not just their toxic waste. By the way, venom. By the way, y'all know the difference between venom and poison? I think pretty much everybody knows these days. You know the difference between venom and poison?
I think poison has to be ingested, or is it the other way around?
I'm asking.
One of them has to be ingested, and then
Yes, but which one?
I think it's poison.
Okay. So poison is ingested, venom is injected. All right. Your immune system cells, your leukocytes, are also going to be key in recovering from envenomation. So let's just say you get bitten by a venomous snake, right? You know, like a rattlesnake or something. That wasn't really in the mood to kill you. Just wanted to teach you a lesson. So him sort of give you a half a bite and send you on your way. There would be enough poison in the bite to make you sick, right? But not enough to kill you quickly. So during the time that you're suffering, your immune system will produce white blood cells that will then produce antivenom antibodies, which will have to remove the venom from your bloodstream and allow you to recover, right? All right. Then it mentions here, they also remove abnormal or damaged cells. Abnormal, damaged, cancerous cells can't be allowed to continue existing in the body. So your immune system is also there in the form of white blood cells to kill them off as well, right? Now it says here in 1 microliter of blood, you have 5 to 10,000 white blood cells, which sounds like a lot. Except when you consider that there's 4 to 6 million red blood cells, right? By the way, who do you think will have more red blood cells, males or females?
Males.
Males,
All right,
And
correct. What's the reason?
because they have
So
more
your
muscle.
muscle mass or something like that.
Greater muscle mass indeed. Males also have a slightly faster metabolic rate in general. So they need more oxygen just to function, right? So I agree. Now, as it says there, most white blood cells are located in the connective tissue proper or in the lymphoid organs. Y'all did connective tissue last semester. So y'all know what connective tissue is. You know, areolar and adipose, you know, connective tissue proper, y'all know that stuff already, right? But it's also found in lymphoid organs. So it's found in the lymph node and the spleen and the thymus and these things, right? Which we'll talk about in the very near future. So this is a slide showing some of your red blood cells and white blood cells. You can see how many white ones you have versus how many red ones you have. Clearly far more red, right? What we're going to do is we're going to be able to look at a white blood cell and based on these characteristics, identify it. You had a question, Nadia? Nadia, I'm not sure you pronounce your name. Your mic is open, that's what I'm asking.
What?
Yeah, your mic is open. Do you have a question? Okay. Moving on. Yeah, I'm gonna ask you to mute your mic for me, Nadia. For some reason I can't mute it. Okay, anyway. Let's talk about the types of white blood cell. We can categorize white blood cells in 2 major categories, right? Obviously, if I say major category, it means that they're minor categories as well, right? We're not going to worry too much about the nitty-gritty of the minor ones. We have enough work to do as it is. But you still need to know what is in the major categories. So, the first big division is granulocyte and agranulocyte. Now, granulo stands for granules, obviously. And cyte refers to cytoplasm, okay? So granulocyte, granular cytoplasm. Now, when you have a biological word and you put A in front of the biological word, what's that? What does the A stand for? What is the difference between a granulocyte and an agranulocyte?
Absence.
Absence.
A means absence, exactly. So granulocytes, therefore, are going to have granular cytoplasm, and agranulocytes are not, right? Pretty simple, right? So there are 3 types of granulocytes that we need, or 3 categories of granulocytes, right? So we have the big category here, and then these are subcategories. But as I said, we're not going to look too deeply into the subcategories. Just be aware of what they are. So we have neutrophils, eosinophils, and basophils. Note, all of them end with phil, right? So all phils have granules in them, okay? So that's the first thing. Once you see a phil, you know it's a granulocyte. Simple as that, right? On the other side, now we have the agranulocytes. They don't have the granules. We have monocytes and we have lymphocytes. Therefore, cytes, no granules, phils, granules, right? Nice, easy way to differentiate between them. Okay, cytes have nothing, phils have granules, right? And cytes have none. Now, we need to be able to look at our different categories of white blood cell here and identify them, okay? So let us start with the phils. So this one here is a neutrophil. Now this weird shaped thing you see here is actually the nucleus of the neutrophil, okay? What we say is that neutrophils have multilobular nuclei. So here's a lobe of the nucleus here. In the little stalk here, there's another lobe, and then another little stalk, and then you see another lobe, right? So here we go. So that's what keeps doing that. That's one lobe. All right, this is not gonna work out. It keeps shooting out for some reason. Anyway, you have 1, 2, 3 lobes here, right? Connected to each other by little stalks. Generally speaking, you're going to have somewhere between 2 and 5, or in some cases up to 6 lobes. Okay.
Sir,
Yes, go ahead.
which one does the phagocytes fall under?
Yeah, okay. I keep hearing people talk about phagocytes, right? Here's the thing. Phagocytism is basically a means of feeding, right? It's like saying herbivore. Saying herbivore doesn't tell me if it's a cow or a goat. All it tells me is that they can eat plants, right? So phagocytes are cells that essentially engulf, then internalize bacteria, etc., and then break them down inside their bodies, the cellular bodies, right? So you have several different white blood cells that do that. Okay?
Sorry, the monocytes would be one, sir.
Monocyte is one, but neutrophils are another. So we can't even say, hey, the phils are phagocytes and the cytes are not phagocytes, because as I said, it's a mixture, right? So these categories here are better than saying phagocyte, not phagocyte, right? I will tell you which ones are phagocytic as I go along still, right? So neutrophil, for example, is phagocytic. These guys love bacteria, and they kill the bacteria by essentially eating them. So they engulf them and break them down on the inside, right? And because neutrophils are also by far the most common white blood cell, normally when you hear somebody say that they're talking about a phagocyte, is a neutrophil they're referring to. right? And they really should call it neutrophil and not phagocyte, but you know, whatever. But we'll work with it, right? So please remember, neutrophils have multi-lobe nuclei, 2 to 5 usually, but can have up to 6. And they are phagocytic. That's their mode of action. So they can engulf and dissolve away bacteria, right? Now, in addition to being able to engulf and dissolve away bacteria, they also contain lysozymes. Well, they use that to dissolve the bacteria they take in, but they also have bactericidal agents. And of course, if something is a bactericide, it's like saying pesticide or herbicide. Obviously, the side is the poison, right? So bactericides are going to be poisonous. So they can pretty much kill bacteria. So the neutrophils, for the most part, will engulf and destroy bacteria. And they can also release chemicals onto the bacteria that will poison them as well, right? So they are very, very versatile. And remember, they are by far the most common of our white blood cells. As you can see here, 50 to 70% of all your white blood cells are going to be neutrophils. But remember, when you look at them, the cytoplasm is granular and they have multi-lobe nuclei, right? And they tend to stay in kind of a purple color because the granules don't pick up acidic or basic stains very well. So they kind of look sort of purplish violet, as you can see. Now, neutrophils are also, because they're so common and they tend to be found floating around in the tissues a lot, they're going to be one of the first white blood cells that you find at a site of an injury. So you get a cutter or a scraper, or whatever it is, it's almost certainly the neutrophil. That's where they come first, right? Now, that said, neutrophils also will trigger other parts of your immune system, right? So they get there first, they assess the situation. They're the first ones that start attacking the bacteria all over the place. When they realize that, hey, the bacteria are getting out of control, they're the ones that will call for the assistance of other white blood cells, right? And they can release chemicals like this lovely one here. This is a leukotriene. We're not to worry about what triene means, but of course, well, let's worry about this part here. So obviously, leuko is leukocyte, right? Which is white blood cells. So the leukotrienes are chemicals that are going to attract white blood cells, more neutrophils, all right, to the area where they can also engulf and destroy bacteria, right? So white blood cells with a phagocytic tendency, like monocytes as well, will be attracted to the area where the neutrophils are, and it will help to control the spread of bacteria, right? So the neutrophils get there first, start attacking and destroying first. They release the leukotrienes to call more white blood cells to come to the rescue, right? They also release a chemicals called prostaglandins. And prostaglandins make it easier for white blood cells to leave the blood and go to the area of the damaged tissue by increasing the permeability of capillaries, right? So basically, the prostaglandins cause the pores in the capillaries to open up wider so that your white blood cells can squeeze out of them and leave the blood and go to the tissues, right? So obviously, your neutrophils are extremely important in your first line of defense, and they help to call the second line of defense in, right? Now, neutrophils don't live very long. They live less than 12 hours, right? That said, they may not even live that long. If you're under, let's say you have a bacterial infection, the neutrophils will just go to the site of the infection and they will engulf bacteria after bacteria. They basically eat and eat and eat and eat until it kills them, right? So obviously, as they're engulfing the bacteria and consuming them, they're breaking them down, then taking in another one and breaking it down. And as they're doing this, they're absorbing poisons, toxins from the bacteria. And eventually they consume so much of the stuff that it kills them, right? So your neutrophils sacrifice their life for you. So keep that in mind. And now you have another one here called eosinophils. So eosinophils, right? The reason it's called an eosinophil is this here. Have you all ever heard of eosin? It's a stain. We use them to stain cells. So eosinophils pick up the stain eosin very well, which gives them sort of an orangish, reddish orange look, right? So basically, that's where the name comes from, right? So neutrophils are called neutrophils because they neutral stains work best on them. Eosinophils are called eosinophils because of eosin, which is an acidic stain. It picks it up more easily. Now notice, eosinophils are only between 2 and 4% of your white blood cells. It's not very many, right? And they're about the same size as your neutrophils. But they have a bilobe nucleus, okay? So when you look at the nucleus of the eosinophil, I'm sure this thing will jump all over the place again. Maybe if I go slow. Nope, doesn't work. Yeah. Anyway, what you're seeing here is a stalk. Maybe if I do it like that. That's that. So here we have one lobe of the nucleus. Here's another lobe. And in the middle here, there's a stalk connecting the two lobes, right? It almost looks like an 8 turned on its side, right? Eosinophils always have 2 lobes to the nucleus, right? And no, neutrophils can sometimes have 2 as well. But remember, neutrophils have sort of a purple color, whereas eosinophils have more of an orangish, reddish color. So even though they're the same size, even though they can have the same number of nuclei, they look very different. So you should be able to easily tell them apart, right? Now, I need to mention what the eosinophils are for. There are not very many of them, right? So you're probably wondering what purpose they serve. Anybody have allergies? If I say antihistamine, does that mean anything to everybody in here?
Yes, sir.
All right. Eosinophils are particularly abundant in people with allergies. And by abundant, I mean around 68%. Eosinophils produce antihistamine. So when histamine causes the swelling and the redness and the sneezing and all of these things, right? The antihistamine is designed to basically block the production of histamine and allow your tissues to go back to their normal state. So it basically is going to stop your allergic reaction. So if you have an allergy, the eosinophils are there to hopefully control the allergy so it doesn't go too crazy. That said, of course, depending on how severe your allergies are, remember that a poor eosinophil is not even 10%, right? So they might not be able to control them in time to prevent something from happening to you. So for example, let's say you have a peanut allergies and shellfish allergies are probably the 2 worst ones. That's an allergies for bee venom. If you have a peanut allergy, right? A severe peanut allergy, literally consuming one peanut is enough to start a cascade, right? Basically what happens is that your blood vessels start to dilate. The muscles in the lungs, the bronchi start to constrict. That narrows your airways as your blood pressure is dropping, right? So your blood pressure is dropping, which means the force of blood carrying blood to your brain drops. Then you constrict your airways, which reduces the amount of oxygen getting into the blood, trying to get to your brain. And before you know it, you have collapsed and passed out, or you're now in shock, right? And if you stay in shock long enough and your blood pressure drops fast enough, your heart will stop beating and you will die. So basically, if you have a peanut allergy and it's severe enough, one peanut can kill you, right? If your allergy is not so severe, the eosinophils will produce histamine, and histamine will cause your blood vessels to constrict, and it will cause your blood pressure to raise. It will cause the muscles in your trachea and bronchi to relax, so air can get in more easily. Okay, so when somebody has an allergy like and they take antihistamine, that is basically what the antihistamine is doing. It's the same stuff essentially that the eosinophils are producing, right? So remember, eosinophils produce antihistamine. Another thing that eosinophils are good for is parasites, right? Eosinophils produce chemicals that kill parasites. So if you have a parasitic infection going on in your body, you're also going to find that your eosinophil levels are much higher than normal. So remember now, as a nurse, if you see that somebody goes and do a blood test, you know the percentage in their blood you're supposed to have for the eosinophils, 2 to 4%. You know the neutrophils are supposed to be between 50 and 70%, right? So just by knowing those two things, if you come back and say, boy, they have a 10% eosinophil count, right? Then you say to yourself, either they have a severe asthma allergic reaction to something, or they have worms, a parasite. And from there, you can start investigating, right? So just knowing what the blood cells do and what their normal concentration is in the blood, you can actually start diagnosing people, right? All right, next one is the basophil. Now, go ahead, Juvin.
Sir, before you move on to the basophil, I just wanted to ask you something. For persons with the allergic reactions to like peanut, when they take the EpiPen,
All right,
that would increase their heart rate, but
all right.
like
Let me
how
tell you.
does it?
EpiPen is called EpiPen because it contains epinephrine. Epinephrine is adrenaline, right? What adrenaline does is adrenaline causes a constriction of your blood vessels. So it squeezes down on the blood, which immediately causes your blood pressure to rise, right? It also forces the relaxation of the breathing muscles. So the muscles of the bronchi and the trachea, all of which make it easier for you to take air in. So it means your blood gets oxygenated more easily. And by increasing your blood pressure, it makes it easier for you to transfer that oxygen to your brain, right? Which of course means you won't lose consciousness, and by a lot, and if the blood pressure keeps high, you won't have a heart attack, right? So that is why they walk around with EpiPen. By the way, I found out about a scam recently. Y'all need to be aware of as nurses. A lot of the EpiPen manufacturers, they have an expiration date on the EpiPens of 6 months. Okay, and you'll eventually see it. No go so. Epinephrine no spoil like that. Those things are still usable 2 years down the line. So if you hear people saying, boy, they've changed the EpiPen every 6 months and the EpiPen is expensive, you can tell them, so look here, keep it for a year. Right? Unless they're
Money making.
But that's all it is about. Right? Because there was even a study done a year or 2 ago. So it's a fairly recent study that EpiPens that were 3 years old were still 90% effective. But they wanted to buy one every 6 months. Right? And some of the prices that they spend can be ridiculous. $15,000, $20,000 for one. Right? Anyway. Honestly, you're going to book up and wait for little medical scams like this as you go along. All right, basophils. Basophils are the least common of all the white blood cells. If you notice here, it's actually less than 1%. Somewhere between 0.5% and 0.75% is the most common figure you're gonna see, right? They are also bilobed, okay? They're between 8 and 10 micrometers in diameter. Remember, your red blood cell is about 7. So they are a little bit bigger than your red blood cells, right? But when you look at them, they tend to start staying very dark blue to purple, right? So they're very, very dark blue. So dark blue that normally if you look at them, it is really hard to even see the nucleus in it, right? I can make out the nucleus. Let me just see if I can trace it here. Oh, this thing going crazy on me. Went over a little bit too much on that side. Right? So this is their bilobe nucleus. This is one lobe on that side and here's another lobe on the other side, right? If you're not looking very, very carefully, it's hard to see it. But it's there. So this has a bilobe nucleus as well. All right. As I said, 8 to 10 micrometers in size, so it's slightly bigger than your red blood cell at 7.5, right? Now, this one, oh, you know what I should have mentioned? Sorry. I should have mentioned the sizes of the eosinophils. Eosinophil is normally between 12 and 14 micrometers in size, right? By the way, can I upload this thing to the same Google Drive y'all gave me? There should be space for that, right?
I believe so, but I'm seeing that this side that you're presenting is also on Moodle.
The slide is, sure. I'm talking about the lecture.
Oh, I'm not sure, sir.
Okay, well. All right, we'll see how it goes. All right, now, so remember, the eosinophils is normally between 12 and 14. Base of neutrophils as well, right? All right. Now, basophils are essentially these are the cells that are going to be one of the prime instigators of an allergic reaction. Basophils produce the histamine, right? So you have the eosinophils making the antihistamine to counteract this, and basophils produce the actual histamine itself. And remember what histamine does? Causes severe dilation of the blood vessels, right? Which causes a significant drop in blood pressure. It also increases the permeability of capillaries, which of course means that plasma is leaking out of the capillaries, which further causes the blood pressure to drop. And it can cause swelling of the tissues as well. So as your blood pressure is dropping, you're swelling up, right? It can also release heparin, which can stop blood clotting from happening as well. So you can imagine you get a cut, you're bleeding out, you're swollen, and you're losing consciousness because the basophil decides that the peanut is too dangerous to be allowed anywhere near you. So it's going to try and kill you to save you, right? Now, luckily, the basophils also release chemicals that attract eosinophils to the area. So as long as you don't have a severe imbalance of the eosinophils to basophils, like in the case of extreme allergies, then you're not supposed to get a strong enough reaction to actually threaten your life, right? Remember, people with more people these days have allergies than ever, including severe allergies. But people with severe allergies are still less than 1% of the people with allergies, right? I will say this though. The percentage of people with allergies now is depending on the country, somewhere between 1 in 4 and 1 in 5. I think it's about 1 in 5 in Jamaica. So 20% of the Jamaican population these days has an allergy, right? And I say these days because things have changed dramatically. In the in the 50s, right, in Jamaica. So a little bit before independence, it was 1 person in 100 had an allergy. Now it's 1 in 5, right? And in many places in the US, it's 1 in 4 people have allergies. Now for the longest time, everybody's like, oh, it's pollution causing it, right? The environment is so polluted that it's causing allergic reactions. But you want to hear something funny? In poor countries like India and Pakistan with plenty of pollution, they have on average fewer allergies than places, for example, like New York and Chicago, city areas, right? In Jamaica, you're more likely to have an allergy if you live in a town and if you live in the country as well, right? What we're starting to realize is that children who spend a lot of time outdoors when they're young tend not to develop allergies when they get older. So there's something about being in a natural environment and exposing your body to different things that could become allergens that helps to train your immune system to say, this is a peanut. It's not going to kill me, right? This is pollen from a grass. It's not dangerous. Don't react to it, right? Whereas when you're in the city, you don't get exposed to all of these different allergens. So your immune system doesn't get trained about what is good, what is bad. So it's more likely to overreact when it comes into contact with some of these things, right? So it's something interesting to keep in mind. That the more time you spend in a city, the more likely you are to develop allergies if you start when you're young, right? Anyway, monocytes. Monocytes are the largest of your white blood cells. It says 15 micrometers in diameter, but they're normally between 15 and 20. Right? I've seen monocytes as big as 26. So they can get huge. I mean, huge for a cell, obviously, right? And they tend to be round or spherical, as it says here, because they're flattened. So I say round. And they tend to have a kidney bean shaped nucleus. Now, this term kidney bean is going to give you the wrong impression. Obviously, if you say kidney bean, in your mind, you're thinking of a flipping kidney bean, right? But if I say to you, hey, look here, here's my kidney bean shaped nucleus. What I like you look at this as which kidney bean you ever see look like that before? If somebody put that on a plate, you wouldn't eat it, right? So instead, think of it this way. Your monocytes have an indentation in a spherical nucleus. So the nucleus is round with a piece cut out of it at some point, right? So keep that in your mind. So when you're looking for cells that are monocytes, don't expect a kidney bean shape. Look for a big round nucleus with a piece cut out of it, right? But if you're asked to describe it, you of course still have to say kidney bean shaped nucleus, right? Because the person who described them 100 years ago happened to come across one with a nucleus that sort of like a kidney bean, and now we're all stuck with that definition, right? I mean, look at this one here. How is that kidney bean shaped? Give me a second. Anyway, so monocytes, they do not stay in the blood for very long. If you notice, 2 to 8% of them will be circulating in the blood at any given time, but they don't stay there long. That's because monocytes will leave the blood normally after 24 hours and then they will become macrophages. Now, usually when you people have heard of white blood cells, they've heard of macrophages. And macrophages are another cell that is phagocytic, right? So remember, neutrophils are phagocytic, macrophages are phagocytic, monocytes that they form from are phagocytic as well. Oh, I should mention eosinophils are also phagocytic as well. So you have lots of white blood cells that can potentially be phagocytic, right? So remember, and keep in mind one more time, when I say a cell is phagocytic, I just mean that particular cell can engulf and destroy bacteria, right? Now, monocytes can also release chemicals that will stimulate neutrophils and attract neutrophils and monocytes, right? So if a monocyte comes across a bacteria or something, or if it turns itself into a macrophage, it can still do the same thing. It releases chemicals. I say, hey, there's plenty of bacteria here. We need help. The neutrophils gather around, and then neutrophils will come in and say, hey, there's plenty of bacteria here. Then they'll release their own chemicals and call even more neutrophils come and other phagocytic cells. And by doing this, you rapidly get a large number of phagocytic cells in the area, engulfing and destroying bacteria, trying to control the spread of the bacteria, so the bacteria can't get into your blood, right? Keep in mind that one of the most important things that these cells do is they prevent these bacteria from leaving your peripheral tissues and getting into your bloodstream. Because once they get into your bloodstream, it is very hard to track them down. They can spread to all parts of the body, right? Now, I'm assuming everybody remembers what fibroblasts do. Fibroblasts, of course, make fibers. Remember collagen and elastin and those kind of things? So if you have a cutter or something, then fibroblasts will come in and help, of course, to reinforce the structure around the cut and then help to reinforce the blood clot that's going to have to form. I'm going to be talking about blood clots shortly, right? So far we looked at neutrophils, eosinophils, and basophils. So those are the phils, those are granulocytes. Then we've just looked at the monocytes, which form the macrophages. So of course, that means that we're left with one more category of cell. And that, of course, is going to be our lymphocyte. Now, lymphocytes are the second most common of your white blood cells. Remember, neutrophils are the most common, followed by lymphocytes. And if you notice here, lymphocytes are between 7 and 8 micrometers in size. So that means that they are about the same size as a red blood cell, slightly larger, right? But not by very much. They're about the size of a basophil. But remember, the basophil is very, very violet, almost blue in color, with plenty of granules in there that are the same color. You can barely see the nucleus in a basophil. A lymphocyte, on the other hand, has a big, obviously round nucleus. So most of this here is nucleus. And the rest of this out here is cytoplasm. You're not seeing any big grains in the cytoplasm. Remember why? Because the lymphocytes are agranulocytes. You're not going to see all those big granules in the cytoplasm, right? That said, lymphocytes are extremely important when it comes to specific immunity. Now, let me ask, do you guys know the difference between specific and non-specific immunity? Have you gotten to that stage yet? You should have, I think. Does anybody know the difference between specific and non-specific immunity? Okay. See, this makes sense here. Non-specific immune responses are designed by the body to essentially stop it from getting infection in the first place, or if there's an infection agent in the body, to try to slow it down or prevent its spread. Doesn't matter what it is, it's designed to to block it off. So for example, neutrophils. When a neutrophil comes to an area where there's a cut, any bacteria it sees, it tries to engulf it. It doesn't matter what it is, right? So neutrophils are non-specific. Same thing with macrophages. They come across any bacteria, anything, it doesn't matter what it is, they try to kill it as well and engulf it, right? So they're not looking for any bacteria in particular. They're just murdering everything that moves. Hence, non-specific, right? Lymphocytes are different. They are specific, right? And by that I mean, lymphocytes aren't looking for just any and every bacteria. Lymphocytes are going to be produced to find specific problems, right? Which is why they're said to be a part of the specific defense. So there are two groups of lymphocytes. One of them is called a T lymphocyte. The T here stands for thymus. Let's see if I can write thymus. What weirdness happening. Right? So the T stands for thymus. That looks like thymus too. I'm assuming everybody knows they have a gland called the thymus, right? It's called a T cell because these white blood cells have to go to the thymus before they become active, before they become useful, right? And they're designed to kill cells that are old, so they can kill your own body cells, right? They can also kill cells that are infected with viruses, right? So let's say, for example, another question. I'm sure everybody knows this. Once you have contracted an illness, a disease, let's say you contract chickenpox, which is a virus, your body's going to produce T cells that are specifically designed to hunt down cells that contain the chickenpox virus. And it's going to kill the cells with the chickenpox virus, right? And for the most part, once you've had chickenpox, your body now can recognize the chickenpox. So if you get exposed to chickenpox again in the future, it can make more T cells designed to look for chickenpox, and it can kill off the chickenpox, right? So you will catch chickenpox once and you will never catch it again, right? When you catch a cold or the coronavirus, the same thing is happening. But for some reason, you can catch multiple colds. Somebody's mic is open. Anyway, the question was, why can you catch multiple colds and catch the corona multiple times? How is that? Why is it different from the chickenpox?
Because there are different strains.
They're also mutating each year.
Mm-hmm. Let's start with the different strains. Here's the thing about strains. When your immune system is trying to identify a pathogen, right? It is checking the antigens on the pathogen. Remember what the antigen is? It's usually a protein that your immune system can recognize as either being self, which means it's a part of your body and it knows what it is for, or being non-self, which means it doesn't know what the hell this thing is, or it knows this thing doesn't belong in it. When you catch the cold, a cold virus, the cold virus has specific antigens on its surface. Now, it takes your body a while to recognize that the antigens on the cold virus as being non-self, that it shouldn't be there. But once it does, so the virus can it gives the virus time to make you sick. All right? So more often than not, the time you spend being sick is just most of the time it takes for your immune system to figure out, hey, this thing that shouldn't be in here. It's causing all of this problem. We need to do something about it. And then from that point on, your body will now make plenty of T cells, and the T cells are going to flood your body, and the T cells are going to look for all the cells it can find with this weird virus on it that it doesn't recognize, and it's going to kill the cells with a weird virus, and therefore stop the cells from making the virus. Remember, when you get a viral infection, your cells are forced to make more virus. So the only way to get over that infection is to kill the cells that are infected, right? So once your T cells do that, it also keeps a record of the antigen. So in the future, if you come across that same cold again, your immune system can almost immediately recognize and say, I know this thing, I've seen it before. And before it can do any damage, your immune system produces plenty of T cells, gets rid of it, you have no problems, right? But things like the cold virus, every year will undergo mutations, as you rightly say, to give you different strains. And the mutations change the antigens on the surface of the cells, right? So when your immune system comes across the cold virus again, it's a totally different antigen, so it doesn't even recognize it again. You have to go through the whole long process of your immune system trying to figure out what this thing is, then finally recognizing it shouldn't be here, and then responding again, right? And that's the reason why the the COVID vaccine doesn't work, because the COVID is mutating continuously, changing the antigens on its surface, whereas the vaccine is being given is based on old antigens that COVID dashed for a long time, right? That's why it just doesn't work. And I'm going to say this, I might be proven wrong, but I highly doubt it. You will never have 100% effective COVID vaccine. The same way you can't get a vaccine against the common cold, you'll never have a vaccine against COVID that works properly, because both of them are, the cold virus is a coronavirus, just like COVID. If you can't do it for the cold, what do you think you can do it for COVID? Anyway.
Sir, what is a flu vaccine for then?
The flu vaccine is called a waste of money. Influenza, which is different from a cold, of course, right? Is another virus. Influenza virus is what causes the flu, as well as gives you full-blown influenza and kills you, right? Influenza also mutates fairly rapidly. Not as rapidly as the cold virus does, but pretty rapidly. Normally, there are hundreds of strains of the flu virus, right? Sometimes thousands, depending on the year. When you take the flu vaccine, all you're doing is that you're taking a vaccine which contain, at the time, and normally, remember now, it takes months and months for the manufacture of these vaccines, right? So you're essentially taking a vaccine that contains information about the flu viruses that were prevalent 8 to 10 months before. That vaccine does not contain any new information. So any new strain, you're still going to catch it, right? And they only contain information about what they consider to be the most dangerous strains 8 to 10 months ago, or the most common strains 8 to 10 months ago. So if you think you can go and take the flu vaccine and you won't catch the flu, you're wasting your time, right? You probably won't catch any of the flu vaccines, flu that was around 8 to 10 months ago. I mean, there's a reason why most people don't bother with the flu vaccine. It mostly doesn't work, because it's always old by the time it comes out, right? Tavian, yes.
So I was asking if every time you get a cold, is it a different strain? Like, what if I have one this week, right? And it goes away.
Same cold twice.
Oh, so it's a okay.
Always different, right? Because if the first time you catch a cold, your body figures out how to fight it, right? So even if you get exposed to it again, you get rid of it long before you get sick. If you catch a cold this week and catch another one next week, it's a different cold you catch.
Sir, so it can be a case of you like just having a weak immune system, like.
All right,
Okay,
let me
understand what
tell
I'm
you,
saying.
there are okay. The most common cause. Remember I said to you earlier that you can't catch chickenpox twice? There are cases in which you can catch chickenpox more than once, right? Here is, generally speaking, when it happens. You're undergoing chemotherapy, which tends to blast your immune cells down, right? So that dramatically damages your immune system. Or you have HIV. HIV tends to kill white blood cells quite a lot, and you need white blood cells, of course, to trigger the response to the viruses. So if you find yourself catching a viral disease more than once, it is normally a very bad sign, right? And the most common cause of it is HIV. Yes, Tessinic.
Sorry, if you're not if you had chickenpox and then you catch it again, no shingles that or something like that.
Shingles is different. Shingles doesn't usually affect you until you're much older. What will happen is that the chickenpox virus will hide in your cells. It will sit dormant. The information for producing chickenpox will sit dormant in some of your cells for decades. And as you get older, your immune system starts to weaken. And that can cause the dormant cells of the chickenpox virus to reactivate. And you start to produce the chickenpox virus again. This triggers shingles. All right?
Sir, question. Don't
Yeah.
find this weird, but if it is that you keep on catching different strain of the flu or the cold, does this mean that you will have like a strong-ish immune system because you keep on having different, your cells keep on finding information on these colds?
First of all, it means you're bad looking. You keep looking upon or you spend so much time around sick people. I mean, as a nurse, you really can't do anything about that, right? I always tell students the best place to get a new disease is hospital. Right? The best place to get a new disease is the hospital.
Sir.
The most dangerous places in the hospital is the waiting room. So may I tell you straight up, as a nurse, don't spend any time in the waiting room. Walk through quick. Right? Because if they were healthy, they wouldn't be there. Right? That's a lovely place for lots of different viruses to interact with one another. Right?
Sir, what would be the best way to just calm thyself against this flu vaccine then? Just continue building your immune system with fruits or vitamin C?
As I said to you, I mean, realistically, even COVID, you remember all the hullabaloo about COVID? Do you know when all was said and done, COVID killed slightly more people per year than flu? Slightly more. And we never shut down the world for flu. Right? Realistically, you don't want to die of a virus. Here's the best thing you can do. Stay young and exercise. If you can manage those two things for the most part, you're fine. Right? I mean, I assume you can manage the exercise part. I don't know how the stay young part are gonna go. But
Sir, the
good luck.
young part go hard.
I've given up on it. And so honestly, that's all I can because I'm sure, for those who are even in their late 20s, when you remember when you were like 14, 15, 10, 12, you get sick today and tomorrow you feel better again and move on with your life. Right? It was like nothing. You get a runny nose, big deal, you come home with runny nose. And in a day, your nose stop run. And when you look, your mother and your father down for the count. Same thing. You carry it home. But your immune system is so flexible at that age, it's like no big deal for you. The older somebody gets, of course, the more vulnerable they become, right? Especially once you pass 50, your immune system starts to charter down at an accelerated rate. I always tell people, nature is only interested in keeping you alive until you're about 30. After that, nature not busy with you. Right? It pretty much ignores you between 30 and 45. And around 50, it is actively trying to get rid of you. Right? So keep that in mind. Anyway, it's 3:44. I want to see if I can reach slide 100. So let's keep going. Oh wait, this message in the chat. Well, of course you're going to die. Everybody's gonna die. I mean, you can't avoid it, right? All right, so that is cell-mediated defense. Remember, T cells produce to kill cells that are infected with viruses, but they're looking for specific cells, right? It also means, but of course, we have B cells as well, I should say, right? B cells are now what we call humoral immunity. B cells are humoral because they produce antibodies. But once again, the antibodies are specific, right? So once you're the same coronavirus, once your immune system recognizes, hey, the coronavirus, we have it, we need to do something about it, it produces T cells to go and kill the cells infected with coronavirus. It also produces B cells, which will then produce antibodies, which will be released into the bloodstream. And these antibodies are designed to attack only the coronavirus. Remember, this is why we said it's a specific immunity. The T cells are looking for a particular virus, and the antibodies are designed to kill a certain virus as well, right? Now, when you did a corona test, they weren't looking for the coronavirus in your blood. They were looking for the antibodies against coronavirus in your blood. And the only reason for you to have antibodies for corona in your blood is if you have corona. It's as simple as that, right? Now, it's the same thing with an HIV test. When you do an HIV test, they're not testing for HIV, they're testing for the antibodies against HIV. And if you have them, only one reason to have them, and it's because you have HIV, right? Now, another type of lymphocyte is called a natural killer cell. These guys are specifically designed to kill old cells and malfunctioning cells, right? They are predominantly designed to stop you from getting cancer, right? The cells get too old, the DNA gets fragile, it's more likely that that it'll become cancerous. So you need to kill them, right? If a cell, even if it's young, starts to malfunction, I mean, realistically, when the cells malfunction, they're supposed to kill themselves, right? Because, I mean, you know, there are cancers, for example, lymphomas, which are more prevalent in younger people, right? The cell is supposed to do something called apoptosis. I figured that was going to happen. Ptosis, right? So this is apoptosis. So when the cell realizes that it's going, you know, if it's going wrong, the cell is supposed to have the decency to commit suicide. If it doesn't, it will start replicating uncontrollably, and then now you have cancer, right? So the purpose of the natural killer cell is to find these cells that do not want to die and murder them. Hence, natural killer, right? And so, obviously, lymphocytes are very, very important. By the way, you always come across people who they drink and they smoke and they everything and they live to be 100. And people are like, you're drinking and smoking every day, you're drunk every time I see you. You don't have liver cancer, you don't have lung cancer. How you do it? Right? Or in some cases, you see people who live to be like 100 and say, how you manage to live so long? And they'll tell you, I shot a whiskey and a cigar every day. No, that's not the reason they live so long. Here's the reason they live so long. Genetics, for the most part. All right? Now, what I'm going to say is going to be a little controversial, but guess what? It's the truth. Everybody who is born, you're born with an expiry date. All right? I mean, eating right and exercising can shift the expiry date down a bit, right? But if your expiry date says dead at 50, and you drink right there, and you drink and you exercise properly and all of those things, it might put an extra 10 years on it for you. So you did at 60 instead. You must have heard of very fit people that's dropping down dead one day, right? or very, very fit people. I mean, I heard of the occasional fit person who caught coronavirus and died. You know, I've had corona 3 times. It was a mild annoyance. If anybody should have dropped dead from corona, on me, right? But here's the thing. One of the things that your genetics will do is that your genetics determines how active your immune system is, right? The more diverse your genes are, usually speaking, the better your immune system functions. The more natural killer cells you produce, right? The better lymphocytes you produce, which means that simply by having good genes, you fight off disease more easily, including diseases that hit you towards the end of life, right? I was even listening to this program that talked about smoking. Does smoking kill you? And one of the persons, the response was, no, smoking doesn't kill you. Bad genes kill you. If you have good genes, you can smoke from now until forever and ever do that thing. But if your genes aren't so great and you smoke, that subtracts from your time on this earth, right? So yeah, the best thing you can do for yourself to be healthy is to be born with very good genes. Otherwise, good luck. Anyway, what I'm going to leave you to review this here. What I want you to be able to do is look and be able to identify what these cells are. Okay, this is what I'm going to give you because I haven't mentioned this yet. This is a platelet, a tiny little guy there, right? But you should be able to recognize the rest of the cells just based on how they look. Okay. Let's talk about iron. Now, on a normal basis, your diet contains between 10 and 20 milligrams of iron, which is not a whole lot, right? And remember, the bulk of iron is going to be used in hemoglobin, right? As it says here, about 20% of the heme iron and only 1 to 2% of non-heme iron is absorbable. And the total body iron content is now between 2 grams in women and 6 grams in men, right? So it's not a lot of iron in your body overall. But once again, so men have a lot more iron. One of the reasons, of course, is because men have more blood. Men also have more muscle, right? Men also have more myoglobin, right? So therefore, men need more iron in the diet. I mean, there's a reason why, for example, your average man tends to crave meat more than your average woman, right? Because literally you want iron from it. And the redder the meat, the better. Because the more that means more myoglobin, which is like hemoglobin that is found in muscles, right? So myoglobin is hemoglobin in our own muscles. So that's why a lot of guys like the nice red meat, right? Because of that. Now it says about 80% of the functional iron is found in hemoglobin and myoglobin, which I just mentioned to you. So remember, myoglobin is hemoglobin you find around the muscles, right? There are also a few iron-containing enzymes like catalase, right? And you also have cytochrome as well, which you will find iron in. So once again, the bulk of the iron is going to be in hemoglobin and myoglobin. And both of those are involved in transfer of oxygen, right? And of course, as we said, females tend to have a smaller store of iron than males. And your response will say, that doesn't make any sense. Females are losing iron more often than males. So why females don't store more iron? Because remember the argument we had last week? As red as it looks, there's not that much blood in it when you have your period. It's just not that much on average. Couple of tablespoons, right? So you don't need a massive storage of iron. Now, iron is called a one-way substance because, of course, it is absorbed your small intestine, and you are also excreted at the small intestine as well. But you do not excrete very much iron unless you go overboard in your iron consumption. It mentions iron is absorbed from the upper part of the small intestine, and you tend to absorb it in three forms: ferrous iron, ferric iron, and heme iron. Obviously, heme iron is your own body's iron that you recycle when you break down your red blood cells. Now, here's the thing. We mainly absorb ferrous iron. And ferrous iron is essentially what you find in your pots. So when you cook with one of those Dutch pots, right? You know, these days people are cooking in copper and aluminum pots. I mean, I wouldn't advise you cooking aluminum, if I'm honest. Get a proper iron pot. Because when you're cooking in the iron pot, believe it or not, the rice is absorbing ferrous iron from the pot. So you're actually enriching the food with iron if you cook the food in iron, right? And if you cook food in copper pots, you're moving copper into the food as well. And we don't have anywhere near the use for copper we do for iron, right? Now this here just shows how iron is transported around. I'm running out of time, so run through the slide for me, please. Ask me later if there's anything you don't understand. Let's talk about anemia briefly so that I can let you go. So anemia, of course, means the deficiency of hemoglobin in the blood, which can be caused by too few red blood cells or too little hemoglobin, okay? So if you are iron deficiency anemia, you have too few hemoglobin molecules, as an example. But if you're losing blood, you're hemorrhaging, you can also develop anemia, right? Now, in the rare case when you have a female who has like a severe problem with the period, and she releases massive amounts of blood. As I said to you, she has a cyst or something, right? Ovarian cysts, as an example, or massive fibroids that can cause them to bleed for weeks. That, of course, can lead to hemorrhage or blood loss anemia. But remember, it is not that common. That said, I will say this. Jamaican women are within the top 10 countries when it comes to issues with ovaries and the uterus. Right? Jamaican women have a lot of fibroids and a lot of ovarian cysts. Right? Top 10 countries, almost 200 countries in the world, you're in the top 10. It means you're in the 5% range for problems when it comes to that. Right? I mean, so yeah. I can almost guarantee that every woman in here either knows at least one other woman who suffers from issues with her period, or is a woman that suffers with issues from her period. Right? It is ridiculously common in Jamaica. All right. Now, a not very common form of anemia is called aplastic anemia. Aplastic anemia is caused when your bone marrow stops producing red blood cells. Right? And it is usually caused by damage to the bone marrow. Now, let's say, for example, you're somebody who's undergoing radiation therapy for cancer. Let's say you have a bone marrow cancer and you're blasting your bone marrow with radiation. These people will tend to develop anemia. Remember, aplastic. And during their treatment with the radiation, you'll find that they're going to need to get blood transfusions, right? And of course, blood loss anemia, which is pretty common in Jamaica. Somebody gets stabbed or shot, they're bleeding out. You're also going to need blood to put back in them, right? Now, you also have something called megaloblastic anemia, which affects women who are low in vitamin B12, right? It causes slow production of red blood cells. And what actually happens is that it causes the precursor cells to the red blood cells to get very big. So you end up with these massive blood cells, right? Huge blood cells. And of course, a very, very big blood cell means that it's harder for oxygen to move into the blood cells. Because remember, blood cells are supposed to be small and thin, so its surface area to volume ratio is small, so oxygen can go in easy, right? So women in particular, you have to be ensure that you take your B vitamins. And the best place to get B vitamins, of course, meat, right? Now, hemolytic anemia, basically in hemolytic anemia, your body is destroying your red blood cells faster than you're making them. Right? So in a case, for example, of sickle cell anemia, you can end up with hemolytic anemia. So those are the major types of anemia, right? That we need to worry about. So we're not even going to worry about the polycythemia. You'll do that when you do pathophysio. We're not going to worry too much about it. All right, it's 4 o'clock. We need to stop. But we're at slide 88. So I'm 12 behind where I should be. Remember we have a class on Friday at 4, right? So I'll be able to catch up at that point. So that shouldn't be an issue. Now we look at, yes, go ahead.
Where you say the bulk of hemoglobin is found in myoglobin and where?
I mean, the iron. The most of the iron is found in the myoglobin around the muscles and in the hemoglobin in the blood.
Okay, sir.
Right? So, I mean, as I said, there are some enzymes like catalase that you need it in, but for the most part, that is where you'll find it. And don't forget what I said to you. When you're cooking in an iron pot, you actually do add iron to the food, no matter what you're cooking in it, right? Which is nice. You don't need a massive amount of iron every day, but you do need some, right? You know, particularly people who like rice in a pot and bun the rice, and them have to scrape the rice out of the bottom of the pot. You get even more iron in the bottom of rice because you have to scrape the pot to get it out. You know, I'm not advocating burning up the rice, obviously, but you know, if you're going to burn the rice, burn it in an iron pot instead of an aluminum pot, right? Because one of the problems we're having is I'm not even sure how big a problem it is yet. But when you cook in aluminum, and remember, you know, y'all grow up with aluminum. So for you, aluminum is a common thing. But aluminum was not commonly utilized until the 60s. Right? If you see a picture, for example, of the 70s in Jamaica supermarket, you don't see one can. It's pure plastic, it's pure glass bottle is in there. Right? So cooking in aluminum pots and stuff is fairly recent. And we don't know the long-term impact of it is. What we do know is that when you're cooking aluminum and these things, just like when you're cooking the iron pot, you're going to absorb aluminum. And